conference over to your host, Julie Schaumann, Director of Research and Quality at the National Institute for Healthcare Management Foundation. Please go ahead.
Thank you very much. Good afternoon, and it is my pleasure today to welcome you all to today's webinar, Medicaid Expansion Under the ACA, Early Takers, No-Shows, and Alternative Models. As you all know, the ACA originally relied on mandatory expansion of Medicaid in all states as the key means of extending health insurance coverage to the very low-income adults who traditionally have been excluded from Medicaid in nearly all state programs. But after the Supreme Court made this expansion optional, states have chosen different paths. At this time, 25 states and the District of Columbia are expanding coverage, while the other half of states are not. Adding further diversity, a handful of states are using or exploring alternative approaches that they view as better suited to their situation. Today, we are very fortunate to have three experts with us to provide an overview of this diverse landscape. Dr. Ben Summers will start things off by presenting findings from his study of states that chose to expand even before 2014 under the ACA's early expander option, and will draw out possible lessons for states that are just now beginning their own coverage expansions. We're particularly proud to have Ben with us today because his study was partially supported by NIHCM Foundation through our very first round of investigator grant funding through our program for research grants. Following Ben, Dr. Sherry Gleed will talk about recent research that she and others have conducted to quantify the financial implications of the non-expansion decision. Robin Rudowitz will close by sharing information that she and colleagues from the Kaiser Family Foundation have compiled about the different expansion approaches being pursued by several states through waivers. Before we get to our speakers, I did want to thank Nancy Shockley, our President and CEO at NIHCM, for her help with planning this webinar and for her vision and enthusiastic support of the NIHCM Research Grant Program that facilitated Ben's work. And I also want to thank our NIHCM colleagues, Katie McDonald, Amanda Parker, and Carolyn Myers, for all of their help with
and from the Agency for Healthcare Research and Quality, and thank them for their generous support, as well as my co-authors on these projects, Jenny Kenny, Arnie Epstein, and Emily Arnson, as well as our excellent research assistants here at the Harvard School of Public Health. So to start with, I'm going to give you a little bit of background on the 2014 Medicaid expansion and the early expansion option under the ACA that has taken place in a couple of the states that we're going to be talking about. And then there are really two projects that are under the same umbrella here. One is a qualitative project where we explored with Medicaid officials their experiences from these early expansions, and then going through some of the quantitative results, looking at coverage impacts and enrollment in several of the states with these early expansions, and then go through some of the potential policy implications of these findings. So as everyone on the call knows, and as Julie outlined to begin with here, the ACA expanded Medicaid as of January 2014 with 100% federal funding for newly eligible people, defined as those with family incomes below 138% of the federal poverty level who had not previously been eligible for Medicaid. And the Supreme Court ruling in 2012 that made this a state option has attracted a great deal of attention in terms of state decision-making, which we'll be hearing more about from Sherry and from Robin. But there's a lesser-known provision of the ACA that offered states the opportunity to expand Medicaid even before 2014 using their traditional match rate. And essentially the way this worked was since 2010, when the ACA was signed into law, states could, if they wanted to, expand to some or all of the low-income childless adults in their states who typically have not been eligible for Medicaid. Sorry, the slides are bouncing around here a little bit, but let's see if we can get back where we were. And this was subject to the traditional match rate, meaning that states were going to have to pay a larger share of this than they will for the 2014 expansion. And some states combine this with 1115 waivers as well to have different flexibility in the way that they implemented these coverage expansions. Our study looked at 6 states that chose this option to expand Medicaid to some portion of the childless adults in their state since 2010. And as you'll see, the expansions differed, and that affects exactly what we were able to study in each state. Here's the map of the study states, and you see that the first 2, Connecticut and the District of Columbia, started their expansion in 2010, very shortly after the passage of the ACA, and then 4 additional states in 2011 that expanded to variable portions of their low-income adult population. In New Jersey, only those under 23% of poverty. In California, it was actually done at the county level, and participating counties could go as high as 200% of poverty if they chose. So our key questions in this project, first was simply, what can we learn about the implementation process that might be useful for states leading up to the 2014 expansion, and then for those states that are not yet expanding but that are still considering, as many of the states are still on the fence looking ahead, what might we be able to draw in terms of useful conclusions? And then for those states that have expanded their coverage and really were targeting newly eligible people, what do we learn from those experiences that can help us interpret what we're seeing so far in 2014 at a national level? The first part of the analysis, as I said, is going to be based on semi-structured interviews that we did with leading state Medicaid officials in these 6 states. And then the second part will be a more quantitative analysis looking at the insurance impacts for these adults compared to control states that were not yet expanding. And in these qualitative interviews, we spoke with 11 officials in 6 different states, either the Medicaid directors, their supervisors, or key policy deputies. And we explored various elements of their experiences, how they did their outreach to enroll new beneficiaries, the level of involvement and support from different stakeholders in the state, impact on beneficiaries, and potential lessons and implementation lessons for 2014. So some of the key findings, first, were that these 6 states were in some ways different than what we typically think of in terms of expanding coverage, because they were building or replacing, in many cases, what they had already been doing at the local or state level using their own money. And so all 6 of these states were, to some extent, covering low-income childless adults, either with partial insurance, sometimes only certain services were covered, sometimes it was fairly comprehensive. And in all of these cases, they took the opportunity under the ACA early expansion to bring in federal dollars to pay for some of what they were already doing. And in fact, 2 of the states in our sample didn't enroll any new adults. They were simply transferring over people from their old program and didn't add any new enrollment. And so when we get to the coverage estimates later on, you'll see we focus on the 4 states that were also enrolling new people in the program. But even in those states, in all cases, Medicaid was providing typically more generous coverage. And some of the areas in particular that we were seeing that states felt were being expanded as they brought people in from their pre-existing program to Medicaid: better mental health, medical transportation, better expanded provider networks. And so at first you might think, well, then how does this apply to 2014? But it turns out that about half of the 2014 expanding states are in a similar situation, building off prior expansions, prior waiver programs, prior state or local funding. So this is not actually unique. This is in some ways a case study for what many of these states are currently dealing with, which is not only expanding to new people, but in trying to figure out how to transition and build off of a prior program. So another key lesson that emerged very clearly in these interviews is that predictions are challenging. And as somebody who has worked on some of the projections related to Medicaid expansion and other portions of the ACA, this wasn't necessarily surprising, but I think is important for us to think about, which is we take a lot of these estimates that come out in advance as to how many people will sign up for a program and assume that these are the right answers and that it's known with great precision. And what we see in these states was, even though these were all programs that had some prior experience covering at least part or all of members of this population, on both enrollment and cost, they were sometimes off by a small amount, sometimes farther off. And in particular, one state had nearly twice as many enrollees in the first year as they expected. 2 other states were not quite that far off, but still underestimated their initial enrollment by 20 to 40%. And then even when we're looking at people who had been covered before and were transitioning into Medicaid, some of the per member per month estimates for contracting with Medicaid managed care plans were significantly off by more than 10% and required revisions in the second year. So this is just one kind of early indication that, that there's a great deal of uncertainty and that we need to keep an eye on these projections as a rough guide, but expect that the truth may not be exactly what we were predicting. Another area of significant interest that we saw in the expansions were that there was much more utilization of behavioral health services than had been expected. 5 of the 6 states, in fact, said that this was a problem, or not necessarily a problem, but a challenge for them, as they had more utilization of both healthcare related to mental illness as well as substance abuse. And in particular, in the states that had the lowest income cutoffs for their expansions, substance abuse was a very common comorbidity. And this leads to challenges because coordination of care, as we know, can be quite difficult between mental health services and the rest of the Medicaid program. And in particular, now you have this overlay with treatment for substance abuse conditions. And one official here described that as the real difficulties in operating a program and get services to people where you have these fragmented different systems. In terms of the administration of these expansions, and this is where we get into kind of some of the potential warnings or lessons that we could apply to other states as they move forward in 2014 and beyond, there were several states that struggled with the burden of new applications. In fact, in one state, this contributed to a lawsuit based on delays in being able to appropriately process all of the information coming in. Another state that was transferring many tens of thousands of people over from their pre-existing program, despite their best efforts, couldn't find a way to get the systems to communicate, and ultimately had to rely on the old-fashioned approach, is what they described it, of printing out their eligibility information one by one and entering each person's information into the new Medicaid eligibility system. So this was kind of a pretty striking example of how the complexity of this eligibility process and information technology issues can loom very large. And unfortunately, most of these states felt that the early expansions didn't fix their IT issues, as they said in these quotes. Everybody, and they meant whether or not you were doing an early expansion, all states are trying to either do a new IT build or fix their current IT system. So this is an issue either way, whether or not you did an early expansion. And another official said it even more bluntly, that they felt that the early expansion, while quite useful on its own, did very little to prepare them for the 2014 expansion. A final point that really emerged clearly in these conversations with these Medicaid officials was how important the political context was for the success of the expansions. In all 6 of these were states choosing to expand coverage before the ACA 100% federal funding kicked in. And so you can imagine then that they must have generally been much more supportive of the Medicaid program and of expanding coverage than those states that are still on the fence when they have 100% funding on the table from the federal government. And they describe pretty uniform support from the key stakeholders, whether it be hospitals, consumers, community health centers, and even the groups that I list here as more lukewarm in their support were still nonetheless positive. The business community, insurers, doctors, there really were no organized interest in these states that were saying don't do the early expansion. And I think that one of the directors described this quite nicely when she said in a different setting where you have really deep philosophical divides, economic divides, and so forth, the opportunities for the inevitable bumps in the road to blow up into bigger issues are much greater. And this was quite prescient as we see what happened over the past several months as the coverage and debate over the open enrollment period in the ACA got quite a bit of political controversy, and in some quarters was viewed as being evidence that the whole law couldn't work, whereas in places like the early expander states, these were seen as bumps in the road that could be overcome. So transitioning out to the impact of these expansions on actual coverage, we turned to a completely different approach. We're going to start analyzing coverage estimates in census data. And to do this, we compared several of the states. In fact, we looked at the 2 states with the earliest expansion, so we had some data post-expansion to compare. And we looked at the childless adults who were becoming eligible based on their income, and we compared those similar income range adults in neighboring states that didn't expand. So our sample of adults 19 to 64 in the target income group, we looked at 3 different types of insurance outcomes: gaining Medicaid, being uninsured, or gaining or losing private coverage. And our data source was the American Community Survey from the Census Bureau. And the real advantage of this survey here is that it's so large and has enough power to let us look at single states and also to look at subgroups within those states. We treated 2010 as a transitional year because the expansions began in that year. And so we have 1 full year of post-expansion data to look at. And the two programs that that had implemented their expansions earliest were Connecticut, and we compared that to the rest of the Northeast Census region, and then the District of Columbia, which we initially were going to compare to Maryland and Virginia, but Maryland had its own partial coverage expansion for outpatient care during this period, so we were limited to Virginia. We did linear probability models for these coverage outcomes, and you can see a little bit of detail there on our methods for estimating statistical significance. And we adjusted in these analyses for age, race, gender, marital status, income, employment, and citizenship, the typical demographic factors. And then we also looked at several subgroups to see were there different impacts for older versus younger adults, for those in worse health or better health, and some of the other factors listed there. But before we get into those estimates on kind of the coverage change, we also had the opportunity in this analysis to get month-by-month data from the states in terms of their administrative Medicaid enrollment reports. And these graphs here show for each of the programs that were expanding to new people, not just transferring from old, what number of people were signing up in this new pathway of eligibility each month. And what you see in all of these graphs is this kind of gradual increase. And in particular, in DC and Connecticut, which started earliest, the end of the study period where we were still able to gather data is really 3 full years. And you see that the slope is pretty steadily increasing. So that we're not seeing that all of the enrollment happened immediately and then and that was it. It really was a steady increase over time in these programs. So then what did we find on the coverage front? We see all these people signing up for the program, but what did they have before? Coverage did they have before, and who was signing up? And that's really what we get at with the survey data. So what you see here, and just in terms of overall increase in coverage, so this is among the income-eligible group of childless adults. We see a 3.7 percentage point increase in Medicaid in DC. That was borderline statistically significant depending on your p-value. And then in Connecticut, which was starting from a lower baseline level of coverage, we see a highly significant, nearly 5 percentage point increase in Medicaid coverage in this group. But then we want to dive into that a little bit. So we're not surprised that when you expand coverage, people sign up. But when we look at who signed up, we see an interesting pattern that's most clear in Connecticut, but also some suggestive evidence even in DC, that the coverage gains were greatest for people who were reporting health-related limitations in the survey. And in fact, in Connecticut, you see that it's nearly 3 times as large a coverage gain in this group of childless adults. Another question that people are concerned about and interested in related to expanding Medicaid coverage is always, well, where were they before? Were they uninsured? Did they have private coverage? And what was the kind of net impact on total coverage? And what you see in DC is that we don't actually have a lot of precision on these estimates, and so we can't comment with statistical confidence that there's a change in the uninsured rate. But what it does look like from the point estimates is that most of this was a change in the uninsured rate. There's little evidence that private coverage was changing much. But we don't have a lot of precision. And in Connecticut, we were able to say a lot more confidently that you can see there's a significant decline in the uninsured rate, 2.8 percentage points, but also a decline in the rate of adults in this income group with private insurance, going down by 2 percentage points. And you put these numbers together, and what you see is that about 60% of the people gaining Medicaid in Connecticut were uninsured before. And meanwhile, we see about a 40% of them had private coverage, and we see that crowd-out estimate that's in the ballpark of what has been shown in most previous studies of Medicaid expansions. But interestingly, if you dive into Connecticut, into those subgroups, we get a more nuanced picture. If you look at people who had health-related limitations, the vast majority of them were uninsured. And this isn't surprising. This is a low-income group of people, and if you have major health limitations and low income, you generally are uninsured in this country, and that's what we see here. We see 11.2% decline in the uninsured rate, so the expansion was making a major dent for this group, and only a little bit of a change in private coverage, though it is statistically significant. It's a small share of the total coverage gain. The story is very different when you look at young adults. So here at 19 to 35-year-olds, we see that actually essentially the full decline in or increase in Medicaid coverages is counterbalanced by declining rates of private insurance. And this matches up actually with what officials had seen in their state, where they had been getting reports of many young people who were seeming to switch from either being on parents' plans or student plans or other sorts of private coverage into Medicaid. Some other results from the coverage analyses, were that there was actually a positive spillover effect on insurance for those who had already been eligible for Medicaid. So these are for low-income parents in Connecticut. As we know from previous research, many people eligible for Medicaid even before the ACA hadn't signed up or were uninsured. And there are expectations that many of these people will be more likely to sign up under the ACA for a variety of reasons, which I'll talk about shortly. And also simply the fact that whenever you expand coverage, there's some spillover as family members or friends might be signing up, more people are talking about it, there's more support among the provider community to get people enrolled. And we did see that change in Connecticut, though not in Washington, D.C. I'm going to quickly gloss over that most of the sensitivity analyses were pretty similar with our findings, though the DC results are less consistent in terms of statistical significance. So overall, key kind of take-home points I would say from these, and then I'll wrap up, is that enrollment is gradual. And you look at these monthly administrative totals, 3 years in, we were still seeing steady increasing coverage rates in Medicaid, which suggests we probably need to be patient as we look at some of these early reports coming out in January, February of the first year of the 2014 expansion. The coverage gains appear to be most concentrated among those with health-related limitations. So this has implications both for cost, but also the public health benefits of expanding coverage. And then I already discussed it at length, the variability in crowd out, but what we see is there's some private insurance that's being substituted in for Medicaid, and it depends on who you're looking at in terms of the subgroups. Is this a good or a bad thing? Well, it certainly drives up state spending if people are switching in, but it depends on the quality of the private coverage they were giving up, and there is a growing body of evidence that in particular for low-income people, a lot of the private plans they have leave them underinsured or at risk for catastrophic expenses. And then there's the welcome mat effect or the woodwork effect, which is this phenomenon of people signing up for coverage who are already eligible, but doing so because the expansion seems to have that positive effect on other groups. We didn't see any similar impact in DC, though I should mention that they already had take-up rates of over 90%. A couple limitations to mention before wrapping up, that these were not typical states. And in particular, they are more liberal in their general ideology and in their leadership currently in governors and the state house. And they are generally more supportive of the ACA than the country as a whole, which is not surprising then that they were the first ones to adopt the expansion. And building off a pre-existing program is certainly distinct than expanding from scratch. So some of these lessons are directly applicable, whereas others might play out differently in other states. Interviewing Medicaid officials has a lot of advantages. They have a lot of keen insights to what's going on in their state. They have both the nuts and bolts implementation as well as the big picture policy in mind. But of course, it's a different perspective than we would have gotten from talking to stakeholders or beneficiaries, for instance. And finally, our quantitative analysis, we only have 1 year of post-expansion data, and so longer-term outcomes are important to keep an eye on, and we couldn't do that yet. And I think that will be true for the ACA as well, that we'll have some interim analyses, but we'll need to keep an eye on the big picture going forward. So in conclusion, cautious optimism that we will see probably steadily increasing enrollment for throughout 2014 and into 2015. There is demand for coverage in this low-income childless group, and especially those in worse health. And it will probably take a fair bit of time to get to that saturation point. Perhaps it will be a little faster under the ACA because of the mandate and because of other features of the law, the marketplace coverage, and a lot of public media attention to this. And finally, there will be, in certain populations, there will be some crowd out of private coverage. There will probably be some positive spillover effects on enrollment from previously eligible people. And how you feel about this probably is quite variable from person to person as to whether this is a good thing to get more people covered and to switch them from private to public if the public is more comprehensive. Or on the other hand, you might see these as cost drivers for the state and issues for concern. So thanks very much for your time, and look forward to hearing the other presentations and your questions to follow.
Ben, thank you. You've really provided some good food for thought for states that are currently expanding this year, as well as for those that might be sitting on the sidelines watching and seeing how things go before they jump in themselves in the coming years. I'm very pleased now to introduce Dr. Sherry Gleed, who is the Dean of New York University's Robert F. Wagner Graduate School of Public Service. Before joining NYU last year, Sherry served for 2 years as the Assistant Secretary of Planning and Evaluation in the U.S. Department of Health and Human Services, and previously had a long and very distinguished
expansion, they give up some opportunities as well. They can't shift existing state services to Medicaid, and there has been a lot of discussion about how certain things like uncompensated care, potentially some mental health services, some other specific programs operating in states could be shifted onto Medicaid and receive federal match in the states that chose to expand. So they give up that opportunity. A second feature that they give up is that they don't get new federal funds. So a big focus of our research has been to think about the federal funds flows associated with the Medicaid expansion, and by choosing not to expand, the state gives up a bunch of federal money, which is just money like any other money. And like any other federal money that flows to states, they also give up whatever multiplier impacts that money might have on local economies. So states are always trying to attract federal money, and they do that because they anticipate that additional federal money will have multiplier effects. By choosing to not accept the Medicaid expansion, the states are rejecting those federal funds and any resulting multiplier effects they might see. On the other hand, states do not completely escape the ACA Medicaid feature by not participating in the expansion, and there are two respects in which that is true. First of all, there is the so-called woodwork effect. If states choose not to participate in the Medicaid expansion, all the hoopla and excitement about the marketplaces and all the advertising and the individual mandate and other things are still likely to lead some people in those states to sign up for Medicaid. These will be old eligibles who will be eligible only for the old Medicaid match rate. The second really important thing, though, is that Medicaid, unlike Medicare, for example, is funded out of federal general revenues. And that means that the general revenues that fund Medicaid come from taxes that are paid by citizens of all the states, whether the state chooses to participate in the Medicaid expansion or not. So when a state governor or legislature decides not to participate in the expansion, they can, in effect, protect state taxpayers from paying the state taxes associated with that expansion, but that decision has no effect on whether their state taxpayers will be paying federal taxes, and those federal taxes will be used in part for the Medicaid expansion. Just to make this very clear, overall the ACA is expected to reduce the federal deficit, but it also shifts the use of funds within the federal budget, and this is really about the federal taxes that are paid that are going to be shifted into the purpose of Medicaid expansion. So just because a state chooses not to expand Medicaid, federal funds raised from taxpayers in that state can still be used to fund expansions in other states. So what does this all mean? Let's look first at the state cost of expanding Medicaid. This has really been the focus of governors and legislatures as they've thought about going forward. Here what we've done is measure the state cost of expansion as a share of state budgets in 2022. So when this thing is entirely phased in and states are on the hook for 10% of the cost of the expansion, based on what we know about the expansion, how much of state budgets will be going to the expansion population. And you can see that this figure rises as high as about 3% and a bit in Mississippi. South Carolina also about 3% of the state budget would be going to the Medicaid expansion. A couple of other things to note here, though. The first one, which I think deserves a little bit of notice, is that if you look at the states that already decided to expand, you can see that the bar for the state cost of the expansion as a share of state budgets is actually negative. So what's going on there? These are states, this group includes states that already had 1115 waivers or had made other expansions, and they now get enhanced federal match, better federal match on those expansion populations. So for many of the states that already expanded, this really was a no-brainer in the sense that the state costs also fell. That's also true of Maine, which is really the outlier among the states that haven't expanded, because expanding Medicaid in Maine would actually reduce state budgetary costs because they've already done some expansion in that state. But even if you look at the states that haven't expanded and face positive costs, on the whole, relative to state budgets, these numbers are not very high. They're particularly not very high if we look at the next slide, which looks at what that looks like once you take out uncompensated care. And here we're looking basically at numbers well below 2.5% of state budgets for most states. So most states, once you look at the uncompensated care savings that they will achieve by expanding Medicaid, the cost to state budgets is relatively modest. Now, okay, what does modest mean? How do we even think about this in realistic terms? How might one make that decision? Well, I'm an economist, and we always ask the question, relative to what? So here, how do we think about those state budget costs? What could we compare them to? And I want to compare them to a few different metrics now. The first one is, how much money does the state give up in new federal dollars that would flow to the state for the Medicaid expansion? And again, here, if you look at Mississippi, which was the state that had the highest federal cost, state cost as a share of budget, what you can see is that every person, the amount of federal money flowing to Mississippi through the Medicaid expansion is about $500 per person in Mississippi in 2016, $1.5 billion in total if they chose to participate in the expansion. Another thing to notice here is that actually the federal funds flowing to expansion states are not any higher, particularly in the states that expanded, than in the states that chose not to expand. So looking at the slide, it's not the decision of states to expand or not seems to have been driven very much by their own, the implications for their own budgets, but not looking at the federal funds flows at all. And even if you look at 2022, when the federal share drops to 90%, you can see that here also Mississippi, people in Mississippi, every person in Mississippi, this is not every uninsured person, but just every person in Mississippi, the federal funds flows associated with this are about $700 per person in Mississippi, extra federal money that would flow to the state if it chose to expand. Now, if we compare the slides that I showed you before about the state cost with the cost around the federal funds flowing, you can see that the federal funds that will flow to states as a share of state budgets are absolutely swamp the state costs. So again, I'm picking on Mississippi because it was the highest number before. The state cost of the expansion amounts to about 3% of the federal budget. The federal money that would flow into the state as a share of the federal budget is about 25% of the state's budget. So the federal funds flows here are just way, way larger than the amount that the state would have to pay, and that's consistent with the idea of the 100% match for a while and then the 90-10 match by 2020. Now, another way that you might think about this, again, trying to compare these numbers and see kind of what's big and what's small, is to think about this money as just money a state might want to go out and get. So states are always trying to attract money, and let's look at how this money, which they can attract by simply agreeing to the Medicaid expansion, compares to other sources of revenue. And one way that we could look at this is efforts states have made to encourage private businesses to locate. So typically, states encourage private businesses to locate in the state by offering them a variety of tax subsidies. Those affect the state budget in exactly the same way as paying out money for the Medicaid expansion. Here what we've done is compare the amount that states pay out annually in benefits to private businesses to attract them to the state to the amount that they would have to pay to attract all that federal money to the state. And what you can see is that in most states that have rejected the expansion are already spending considerably more money than the state cost of the expansion to attract private businesses to the state. So these are states that are in the business of attracting money. They've just decided that this is not money that they want to attract. Another way of looking at this is maybe how does it compare to other sources of federal money that states have worked to attract? And here we've compared it to federal highway funds and federal defense funds, two big sources of federal money that states are eager to get. On average, the state costs of the federal funds that you would get from the Medicaid expansion are about 2.5 times, 2.35 times to be precise, average highway spending, federal highway spending that goes to states. So the Medicaid expansion is very large relative to federal highway funding, and it's about a quarter as high as federal defense funding that goes to states each year. So if you just think about how you get federal money, you could get federal money through defense contracts. You could also get federal money through Medicaid expansion. The money you get through Medicaid expansion on average is about a quarter as large as defense money in some states. Again, Mississippi, for example, the Medicaid expansion would be just as large as annual defense spending in the state. So it's a big source of federal revenue that I think states will ultimately be interested in grabbing hold of. Now, just turning to the last bit of this, as I said before, even if you decide to say no, you can't remain completely separated from the Medicaid expansion in those two respects because of the woodwork effect and because of payment of federal funds that are now diverted to the Medicaid expansion. If we look at the woodwork effect, this is just from the December enrollment reports Even in states that did not participate in the Medicaid expansion, you see substantial numbers in some states of people who have signed on to Medicaid, presumably because of the increased publicity and increased information about how you might do that comes about through the website. So there certainly are going to be some costs to states and some additional federal money flowing simply because of the ACA other expansions that are taking place. And what about that federal revenue that states are paying out? This analysis actually stems from work that Daniel Patrick Moynihan started many, many, many years ago, looking at the flow of federal funds associated with different programs. The basic insight being that general revenues are collected across the country and they flow back depending on how federal programs are structured. So general revenues come disproportionately from states with higher income residents. So general revenues are somewhat redistributive, and federal programs distribute money in different ways, in this case according to how many people are uninsured and have low incomes. So if we look simply at the federal funds flows of not expanding, so if states choose not to expand, how much money flows out of the state and how much money flows into it. So the ways that we did this analysis is to say, let's just assume that all states decide to expand except a given state. What happens to the flow of federal money from and to that state? The first thing to note is that for every single state that you might look at, choosing not to expand means that federal money flows out of your state. That is, general revenue funds that are collected in your state flow out and are spent to pay for expansions in states that are expanding. And in some of the states that are not expanding, those numbers are very big. In Texas, $9 billion will flow out of the state on net by 2022 to fund expansions in those states that do choose to expand, because general revenue funds collected in Texas will travel to the other states. So that $9 billion is very large relative to the amount of money the state would have to kick in out of its own revenue to pay for the expansion. So overall, who gains and who loses from not expanding? The losers are the low-income non-expansion state residents who are going to remain uninsured because the Medicaid expansion doesn't take place. But there are also other losers. Like any other flow of funds, the fact that money isn't flowing into the state means that money won't be spent. So there are people who are employed in healthcare, for example, who will not see the benefit of those federal funds. And the multiplier effects mean, just like in any other case, just like you would be making the case for any other state incentive to attract money, that other businesses would also be affected. The gainers, on the other hand, are taxpayers in those states that do choose to expand. So ironically, the decision of states not to expand is actually a benefit for the expanding states. It costs them, in effect, their taxpayers, less to pay for the expansion. And the other gainers are non-expansion state residents who pay high taxes and are not particularly affected by the Medicaid expansion. So the structure of this means that the winners and losers are not only concentrated in these states, but are actually spread across the country. So let me stop there. You can find all of the data in the briefs that we cite here on the last page. Thanks very much.
Sherry, thank you for a really excellent synthesis of what are some very complex issues. You've given us a very good feel, a concrete feel for the magnitude of dollars that are involved in this non-expansion decision. Our final speaker today is Robin Rudowitz. She's the Associate Director for the Kaiser Family Foundation's Commission on Medicaid and the Uninsured. And among the many other issues related to Medicaid and the ACA, Robin has been closely following the situation with state waivers. She and her colleagues published a fantastic brief on this topic last October and will soon be releasing an updated version, so definitely be on the lookout for that. Robin?
Good afternoon, everyone. I'm trying to scoot back to the beginning of these slides. Thank you for participating and having me on the webinar. I am charged again with talking about alternative approaches to implementing the Medicaid expansion, and these slides largely draw on a paper that's forthcoming, hopefully early next week, related to the ACA and the waivers so far. So I'll have you go back to look at our website next week. So I will move pretty quickly because, of course, by this point of the webinar, everyone already knows that Medicaid is a key cornerstone of coverage under the ACA. And I just show the next picture because it's our sort of picture of this. Prior to the ACA, people needed to meet both income and categorical eligibility requirements to get on the Medicaid program. So the ACA was really designed to fill in the gaps in coverage, and as the picture suggests, in 2014. Of course, since we sent in our slides for this webinar, we have actually updated our map, and we have now moved about 6 states into a new category called open debate, because this picture is really fluid and states are constantly reevaluating and evaluating their decisions on the Medicaid expansion. And those states are Pennsylvania, Indiana, Missouri, New Hampshire, Virginia, and Utah. And the reason why we move them is because either the governor has come out with a new statement. In Virginia, of course, there was a change in the governor. There might have been legislation passed in one house of the legislature, or there's also potentially a waiver pending or a proposal out there. We are, of course, watching what lots of other states are doing as their legislative sessions proceed, and we're also watching what happens in Arkansas as they debate funding for 2015 in their Medicaid expansion program. So the majority of states, or there are really 2 ways that states can implement the Medicaid expansion. They can follow the prescription as provided under current law and file a state plan amendment, or they may seek a waiver. And really most states, so the large majority of states, are going to implement the Medicaid expansion using a SPA, or a state plan amendment. So they'll comply with federal law, but that doesn't mean that all the expansions will look the same across states. There's lots of flexibility within the law for states to look at different benefits, arrange their cost sharing, and certainly a lot of flexibility on how they deliver care and services to the people who will enroll. But of course, when we talk about alternative approaches, people are really interested in what's happening with waivers. So what's happening with different approaches that don't comply with federal law. So to date, CMS has approved 3 waivers to implement the Medicaid expansion in a way that they couldn't have done just under current law. So that's Arkansas, Iowa, and Michigan. And Pennsylvania has a proposal. It had been open for state comments, and they are in the process of evaluating those comments and will potentially submit that waiver to CMS. And a few states, which I'll talk about at the end, are continuing to use waivers for coverage, largely to maintain coverage that was in place prior to the ACA. So when we talk about waivers, I just want to make sure that everyone understands what an 1115 waiver is. And an 1115 waiver is really designed to allow for experimental, pilot, or demonstration projects that promote the objectives of the Medicaid program. So it authorizes the Secretary to waive compliance with federal law and provide federal matching dollars to states for costs that they otherwise couldn't get federal match for. These waivers, both before the ACA and now, need to be budget neutral for the federal government. So over the course of the waiver, it has to be estimated that the federal government would not spend any more than they otherwise would have. There is a lot of negotiation with these waivers back and forth with states, CMS, and with the Office of Management and Budget on the budget neutrality requirements. The ACA also required HHAs to put out rules that allow for better public opportunities to comment and make the waiver process more transparent. Waivers are generally approved for 5 years, but there are some changes to that related to the more recent waivers. And again, looking at the history of waivers, prior to the ACA, again, there was no real route for coverage, particularly for childless adults. So because there was no other option, the Secretary has often, waivers have been used to provide coverage to this population. And because the waivers had to be budget neutral, and because there were no other options available for coverage, states were able to do things like impose premiums or cost sharing, enrollment caps, things that you can't otherwise do under current law. With the ACA expanding coverage to nearly all individuals with income up to 139% of poverty, with these extra dollars, it really changes the frame within which waivers are evaluated. And of course, we know that in the states that don't implement the Medicaid expansion, there'll be large gaps in coverage, and Sherry certainly covered the issues related to the federal funds. So when thinking about waivers, CMS has offered and issued a bunch of guidance about what types of waivers they might look at related to the ACA. So they've said there will be no enhanced matching for partial waivers. So early on, states had said we only want to expand up to 100% of the poverty level. So they had issued guidance that says that states can't get federal match or the enhanced matching dollars for those type of expansions. There's also no waivers that would be approved with enrollment caps. There was also guidance issued related to how states can move forward with waivers for premium assistance and the guidelines that states had to follow to get those waivers. And there's also different authority that states would need to apply for under if they wanted to do any waiving of cost-sharing requirements. So we have a small set of waivers to look at, and we could try to draw out some themes from this small set of waivers that have been approved. So the 3 that were approved, 2 out of the 3 use premium assistance, 2 out of the 3 use premiums, 2 out of the 3 are looking at healthy behavior incentive programs. Only Iowa really has a benefit restriction that was approved. So we'll explore those in a little bit more detail. And Pennsylvania, of course, has this waiver that is proposed, and it really picks up on a number of the other provisions in some of the other waivers. And again, that one has not been submitted to CMS formally yet. So we can learn a lot from what CMS has done in approving or denying provisions that were in the recent waiver proposals. And these decisions really also set more guidance and limits so other states thinking about waivers, can look to these waivers and see what has been approved or not. So essentially, they have approved 2 waivers that look at premium assistance. These have largely complied with what was in the guidance. So they exclude certain populations, they have to provide wraparound for benefits and cost sharing, and there is a shorter time period for these waivers. CMS has also approved premiums for individuals with incomes between 100 and 138% of the federal poverty level, up to 2% of income. And this is really about the same as what individuals would face in that income band in states that didn't expand if they were to purchase coverage in the marketplace. There have been very limited approval of benefit waivers. And again, 2 of the states also have these healthy behavior incentive programs, which are these incentives tied to, if you comply, you could reduce your obligations on premium cost sharing. It is also true that the protocols, so really the details, need further approval by CMS. There are also some things that have not been approved. Premiums for individuals under 100% of the poverty level have not been approved. Neither has cost sharing beyond what's available under current law. And a few requests for benefits that were requested to be waived were not approved. Pennsylvania's waiver has a work requirement included in their proposal, and CMS has never approved a work requirement condition to participate in Medicaid, but that is part of the Pennsylvania proposal. Again, a few states are continuing to use waivers for coverage. These are waivers that are not eligible for the enhanced ACA matching funds. So a few states are keeping their waivers for populations above 138% of the poverty level. Minnesota and DC continue their waiver programs in Medicaid. And then it's Massachusetts as well as New York and Vermont who have waiver extension programs that are requesting to use Medicaid funds to provide assistance to individuals above 138% of the poverty level to help those people purchase coverage in the marketplaces. There are a few states who also have waivers not moving forward with Medicaid expansion. So again, these waivers are not eligible for the enhanced match in Indiana and Oklahoma, as well as Wisconsin. And due to time, I'm not going to go into all the details of those waivers, but certainly can answer questions. So looking forward, there's no deadline for states to participate in the Medicaid expansion, and as we discussed related to the map, there's lots of change that's still occurring as particularly as states kick off this legislative session. We will be watching to see what happens, particularly in Utah, Pennsylvania, and Indiana, because that's where waivers have been either proposed or discussed. We'll also have to see how the public notice and transparency rules continue to work and what effect the public process has on these waivers, and certainly how what we'll learn as these waivers go forth and what we can learn about them going forward. So I will stop there and gladly take lots of questions.
Robin, thank you, and I predict you'll get a few questions because we've had quite a bit of interest in what the other states are doing and some views on that. You really provided a nice overview of what's a complicated and fluid situation with the state waivers, and I'm sure we'll all be watching that. At this time, our operator will come on the line and explain how you can ask a question if you're joining us by phone.
Thank you. Ladies and gentlemen, if you would like to ask a question, please signal by pressing *1 on your telephone keypad. If you are using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. If you have signaled for a question prior to hearing these instructions on today's call, please repeat the process now by pressing *1 again. We'll pause for just a moment to allow everyone an opportunity to signal for questions. And our first question comes from David Ramsey. Please go ahead.
Hey, this is David Ramsey from the Arkansas Times. So I've been following the Arkansas waiver closely. And my question is about sort of cost comparability or budget neutrality with these waivers and the evaluation process. It seems like in Arkansas specifically, it's a little fuzzy, and I guess you kind of get into counterfactuals where you're trying to imagine what would have happened if you had done traditional Medicaid expansion as opposed to pursuing one of these waivers. What's the history of these waivers in terms of attempting to be cost neutral in the way that they're
otherwise would have spent without the waiver. So that is a projection as well. But you know, there's lots of back and forth that goes on, particularly around the determination of budget neutrality and getting the waivers approved. And states do need to submit their costs, and they're evaluated, you know, relative to what they had said, and it's usually over the 5-year period of a waiver, but for these premium assistance waivers, they were approved through the end of 2016. So not sure how much more I could say about budget neutrality.
I'll jump in with a question that has come up by a couple of questioners, and it's about the enrollment numbers that have been released in recent weeks, and one person said, does it surprise you how few states are actually tracking if the Medicaid enrollees are new to the program or just re-enrolling? And another questioner said, any thoughts on how this 6.3 million figure, how much of it's from the expansion in the states? And I throw that open to any of the speakers.
I could jump in just because I could also put in a plug for a brief that we just released yesterday, which is Medicaid enrollment under the ACA, Understanding the Numbers. So we tried to sort out some of the numbers, both on applications and enrollment that are happening under the ACA. And it's a little bit hard to draw lots of conclusions from those numbers because states are reporting different things. And you know, as you just said, some states are reporting re-enrollees or renewals as well as new enrollees. So we don't have the ability to break that out right now, but we did look at the 6.3 relative to recent trends in enrollment because we were able to put out our June 2013 enrollment data. You know, so relative to trends, the 6.3 is quite a large number relative to trend.
And I have a comment that kind of builds off the question and also relates to what several participants had put in as a question. So having spent a fair bit of time with this project talking with Medicaid officials, looking over the enrollment numbers and that sort of thing, it doesn't surprise me that this is harder to tease out than you would think. And the reason for that is that the states are doing everything they can to keep the program running, to get people signed up, to process applications, to then actually deliver care, you know, get people the benefits that they need through their coverage. And these data issues are not without significant trade-offs in terms of the time and energy spent to collect them. And so if you don't need to know at the exact point of enrollment whether somebody is a new or an old eligible or a renewal or not, it may not be something that gets recorded. And after the fact, sometimes these data can be analyzed to do that. And in our study, for instance, we went back with information we got from the states to look at their total expansion population and then to net out how many people had transferred. But we had to do that as a kind of a rough approximation. They couldn't, most of the states couldn't tell us precisely who was or who wasn't transferred without doing a significant amount of additional work. What we could do is take that raw total of the enrollment in the pre-existing program and subtract it out, a very rough approximation. And one of the artifacts you see from that approach is in the Minnesota enrollment curve that several people asked about on the online questions. When you subtract out that population, there are some just natural ebbs and flows in the total enrollment in Medicaid. And because of some seasonal effects or economic fluctuations, that ends up kind of showing up as an artifact in the data because we've had to just subtract out a single number from each monthly enrollment. And it makes it noisier than you'd think. So I'm not surprised that this has happened. I do think the numbers will get better with refinement. And then the ultimate question I think most people are most interested in, which is what's the net impact on coverage of these expansions? That ultimately you need another data source entirely. You really have to have population-based data so you can see those who didn't sign up as well, and you can look at total coverage. And we're getting some early estimates from some of the telephone surveys from Gallup reports, for instance, that that the uninsured rate does seem to be going down early this year in a report that Gallup put out about a week ago. But it really will take some time for all this to sort out enough to have a clear idea of the overall coverage impact.
Thank you. Let me ask a quick follow-up on that topic from one of the questioners. That he is reporting that Rhode Island, for instance, has noticed people who are newly eligible for Medicaid dropping out of the program, declining to join because of stigma, and then trying to provide or to apply for the subsidy via the exchange, only to be denied because they are in fact eligible for Medicaid. Have you speakers heard of this happening?
I have not.
I mean, it's certainly plausible that there would be some people who would have that preference, but the law doesn't allow for that. And if you're eligible for Medicaid, you're not eligible for tax credits. I have not heard that this is a widespread issue, but certainly anecdotally, it's possible.
Yeah, we have not heard that either, and I think when you look at focus groups and people who come to apply, people are really just interested in obtaining coverage, and most people on Medicaid report, that they're happy with their coverage over the years of the program. So,
Do we have any other callers on the line? I don't want to cut off their questions.
Sure. We have a couple of questions on the phone lines.
Okay.
We have a question from Becca Aronson. Please go ahead.
Oh, yes, this is Becca Aronson from the Texas Tribune. And first of all, I was just wondering if someone could expand on exactly what they think that the impact for Texas will be for choosing not to expand Medicaid. And also, if somebody is comfortable speaking on a more political side of things, how do you think a state like Texas would be able to compromise on some sort of Medicaid expansion?
Well, this is Sherry. The implications for Texas are a lot of uninsured people who will not get coverage, and substantial dish cuts coming down the pike. A lot of money being diverted out of the state because it's the largest of the states that's not expanding. So it's a very costly proposition from a general federal funds perspective. It's very hard to predict anything politically. I guess I remain consoled by the experience of the original Medicaid program, which took a long time for people to come around, but eventually they did. I imagine that something similar might happen here. Perhaps once the program is going in enough places, the political heat around it will fade. I don't think it would be a programmatic change. I think it would be a political change political change in the sense that some other issue comes to dominate the ACA as the hot button political issue that would allow Texas to move.
Thank you, Sherry. I had a couple of questions about the basic health plan, and let me read the longer, more complex one. It says at least a dozen states have expressed interest in the basic health plan. At least one state has done an analysis which indicated that it would be advantageous to pursue this option if the health benefit exchange rates exceeded 12% of the current marketplace in the individual market. While we're early, clearly, we are seeing some worries about adverse selection and higher rates next year. So they're asking sort of what your view is on the basic health plan going forward, and that's similar to the other question.
I'm not sure we know the answer looking across states, but Minnesota is one of the states that I mentioned them as one of the states maintaining their Medicaid coverage for individuals above 138% of the poverty level, and they stated that they would like to move forward with the basic health plan to transition those individuals between 138 to 200% of the poverty level.
And one interesting finding from our study that it didn't present, looking in Washington, D.C.'s program where they did expand with the early expansion option up to 200% of the federal poverty level, when we looked at the income band of 138 to 200%, we actually found that the coverage gains there were bigger. They were actually statistically significant in all the models for that higher income group, whereas those under 138 had those more marginal coverage gains. And this is interesting as kind of a suggestion that the BHP model really might be reaching a group that would be interested in coverage like this. The previous question about would anyone in this income range really want to be on private coverage instead of a state program, but in DC that wasn't the case, and we saw those coverage gains as even larger. So I think on the enrollment side, if some states do go forward with BHP, this might be a way of also boosting enrollment further.
Thank you. Were there any other on the line?
We do have a question from Kate Lewandowski. Please go ahead.
Hi, this is Kate Lewandowski from Community Catalyst, and I had a question for Sherry. I found your data about Maine really interesting, and I just wanted to clarify about your methods. Maine often gets characterized as an early expansion state, but because many of the early expansion efforts that were made there got rolled back as of January 1st, do your notes in your slides about Maine take that into account?
No, because the main analysis is based on the Holohan analysis, which goes back before the cutbacks. So I'm actually not sure how those cutbacks affect how Maine would now do. So this is based on where Maine was 6 months ago. Does that make sense?
Yes, thank you.
Thanks, Sherry. We had quite a few questions sent in earlier people who were thinking about provider capacity issues related to expanding the Medicaid population. One questioner asked if states have considered or enacted policies to address capacity issues. People were worried about low reimbursement rates and providers opting out of the networks, and wondering also about how expanding the number of people covered by Medicaid might affect access to service for people with disabilities, and ways to incentivize doctors to accept more Medicaid patients. Does anyone want to pick up any of those threads?
Yeah, I can talk a little bit about some of the insights that we heard from the officials in the interviews on the early expansion. For the most part, they were pretty optimistic that this was not going to be the limiting feature in the ability of the expansion to improve access to care. There was not, I wouldn't say there was a great deal of enthusiasm that the primary care pay bump, part of the ACA for 2013-2014, was going to be a driver of expanded access, but more just generally that they felt that they had adequate provider networks in their managed care plans, and that the states that weren't using managed care heavily also had adequate provider participation. I think sometimes the numbers, we kind of lose track of the denominator. I mean, these are big changes in Medicaid, but right now, if we look at the baseline kind of rates of coverage in the country, and we look at the baseline size of the Medicaid program, you would be easily tricked into thinking that we're going to triple the size of Medicaid with this expansion, which we're clearly not doing. So there will be certainly targeted areas of shortages that may be worse. From several of the officials in our interviews, we heard concerns about specialty care, in particular in rural settings, though they basically said these are pre-existing problems that really aren't largely impacted by the Medicaid expansion. This is kind of status quo issues that we need to address, whether or not we also bring in the childless adult population.
We probably have time for maybe one or two more questions on the phone. If not, I've got a couple of other that have been sent in.
Ladies and gentlemen, as a reminder, if you would like to ask a question, please press star 1 on your touch-tone phone.
And in the meantime, Robin, let me maybe put you on the spot a little bit. We've had, as I said earlier, a lot of interest in what individual states are doing, so I don't know if you are up on absolutely every state in the latest minute, but people have asked about one for Indiana. They wondered what your opinion was about the governor's interest in expanding Healthy Indiana plan in lieu of expanding Medicaid. We had another question about Montana. I believe last year they lost the expansion vote by 1 vote, and wondering what the outlook looked like for this coming year. And someone also asked about Oklahoma. And you've already talked somewhat about Pennsylvania, obviously, but there was some interest in that as well.
Well, Indiana and Oklahoma had some coverage through a waiver prior to the ACA. They're both states that right now are not moving forward with the expansion. They both received these one-year extensions of their current program to maintain coverage. But because that coverage is limited in some way, either there's a cap or the benefits are not equal to what they should be under the what's called for in the law for the Medicaid expansion, or there's cost sharing involved, those programs are not eligible for the enhanced match. The governor in Indiana has expressed interest in that using their waiver proposal, had wanted to use that as the foundation for their coverage expansion, and they're still trying to have some debate with CMS about that waiver. CMS has indicated that the cost sharing is an issue, so I think that's going to be something to continue to watch. And Montana is one of the states that we didn't move to an open debate category, but it's certainly on the list of states to watch, as it was a very close vote last year. The governor has supported the expansion, but there has not been any activity yet this session.
There are no questions on the phone lines. Please continue.
Thank you, Robin. Thank you, operator. I think that then wraps up today. We're out of time. We've ended right on schedule. I really want to thank our excellent panel of speakers who took time from their busy schedules to share their expertise with us today. And also wanted to urge you to visit our website. We have the slides posted there and other background materials. You can find out more about the grant programs that funded Ben's research, and also register for 2 new webinars that we have coming up in the next week and the following week on also interesting topics. So thank you very much for joining us today, and we really hope to have you again with us in the next 2 weeks. Thank you.
Thank you. Ladies and gentlemen, this concludes the conference call for today. We thank you for your participation. You may now disconnect your line and have a great day.